presentation. It's not very easy to talk about retinal surgery. We've seen very great presentations here on anterior segment, corneal transplantation, retina clinical and surgical as well. But my task here is to talk about retina surgery, but not only on retina surgery those days, but a resume of retinal surgery since years ago. And I'm going to start off with after doing my fellowship back in 1996 in Brazil, and then I did another fellowship in Toronto, Canada by 1997, and then for those days, nowadays, the retina surgery, the evolution, what happened before, what we did before, what we do today, what we don't do anymore, what we keep doing or not doing. So my subject is combined scleral buccal and parsplenial vitrectomy as a primary procedure for pseudophakic retinal detachments. So what does this mean? If we get today most of the surgeons, they do retina surgery without a buccal or a band. I would say 240 band or a 276 buccal. Either you have normal, easy case, a retinal detachment, you only go ahead and do a buccal, that's all, or you do a vitrectomy, or you do both. The individual percentage of success for each procedure varies. If we have a great, plain, easy retinal detachment case with some subretinal fluid and macula on or off, if you don't have a PVR, it goes on very well with scleral buckling alone. But if you have a more complex case with PVR or traction, you're better off doing a vitrectomy. But in the same case, and now I'm putting into perspective not only the retina, whether it's attached or not attached, the macula on or off, but I'm including here the pseudophakic and the phakic patient. And we chose to work with the pseudophakic patients. The pseudophakic and aphakic, some patients are included in the study as well. They have a better result of doing the two procedures combined, which means scleral buccal and vitrectomy rather than only one or the other. So that's where I did my fellowship after one fellowship in Brazil. This is in Toronto Western Hospital, University of Toronto. And now our service is in Brazil at the iBank Foundation of Goiânia, Brazil. And at the iBank Foundation, we do all sorts of ophthalmic management. We do retina, we do cornea, we have fellowships, we have residency programs, and we have, fortunately, the best stuff to go on and to practice retina surgery. And now, I'm just gonna invite you to join our society. It's a Brazilian Vitreoretinal Society. We call this BRAVS. And presently now, today we are having in Vienna the American Retinal Society Specialist Meeting. And our team, the Brazilian team, is the second group, losing only for United States. We have over 1,000 members in Brazil. Some are not from Brazil, some are from US as well. We have like Borac Cooperman, which is there. And actually, he's, I would say he's half Brazilian, half American. And he's always joins us in our presentations, not only in these congresses, in Brazilian congresses as well. And we invite you to take part. Talking about retinal detachments, the most complex retinal detachment I'm going to talk about now in this presentation, what could be most complex would be inferior retinal detachment, because in these cases that I'm going to show you, we are comparing pseudophakic and aphakic retinal detachment patients with not complex retinal detachments. I mean, not PVR, easy cases. And then I'm going to go on and proceed with some videos showing you how we manage